thank you all for being here.
Absolutely.
Yeah.
What a great day to kick off the conversation with the three of you. Today our conversation is, we're going to spend a bit of time on our theme, harnessing harmony. It's a word that I have learned several times to repeat. It's harnessing harmony. We don't have to mess it up. But by talking about the critical foundations needed in order to build on the future. Not one of these panelists needs an introduction. Everybody knows who they are, and they're all industry stalwarts, and not one of them needs an introduction. But as I get my first question, I'm going to have each of you say a few words and introduce yourselves, and then talk a bit about what we need to do. I'll start with you, Dave. We think about innovation, we think about several foundational elements that are needed to evolve into a large-scale innovation of the future, because there are multiple things that we build on. If you take a moment to introduce yourself, and from your own perspective, as an educator for many years and now where you are, give your perspectives on some of those elements would be fantastic. Why don't we start with you?
Sure. So I could do the introduction quickly. My name's David. Because I'd rather use my time trying to answer that question.
Of course.
So listening to you, Sean, in the introduction, when you were up here, you were talking about it's easier now to get in to see the doc and you could use the technology. Then you jokingly said, hey, it would be great to know what I paid or what my out-of-pocket is. And the other thing that I was thinking when you were talking about that is there's another person in this situation, the actual clinician, right? So what we're trying to do at Oracle is actually fix all of those problems by creating an open, connected platform that not only allows that consumer engagement that you described perfectly, but Oracle Financial Services runs 80% of the world's credit cards. And what is that? Well, that's just an agreement between a bank and a merchant, and they agree that this isn't fraud and we're going to pay this bill. We can do that same thing in healthcare. We literally have payers and providers that are spending a lot of money in a system that doesn't work as smoothly as that. So that to me is totally doable, as well as that poor clinician that saw you. That clinician is spending so much time, whether it's the NP or a PA or a physician, clicking away. And we announced a couple months ago our new clinical digital assistant, where I demoed seeing a patient who came in, and I got information about this woman's food insecurity. I was able to talk to the patient, examine her post-pneumonia, increase her meds for diabetes. It was your regular doctor visit. The unique part about it was the computer was behind me and I never touched it. So we don't want to go from 50 clicks to 30 clicks. We want to go to 0 clicks. So when we talk about that foundation, I think fundamentally, healthcare is people caring for people. It's built on trust. And we have to make the data flow so that wherever you are, the consumer, the payer, the provider, the mom at home, the public health person, we're providing you a user experience and the right technology at the right time so you can do what you do, which is either try to get better or take care of a patient.
No, great, thank you. It's an interesting thing. I'll switch to Lynn. You're a clinical leader. David pointed to you a few times, so it'd be great to get your perspectives and, of course, an introduction and great perspectives from you on some of this growing importance of technology, as he talked about, having that information. Is Gen AI doing some of it? And what are your perspectives? Would be great to start with.
Yeah. Well, thank you for having me. I'm Lynn Simon. A little longer introduction. I'm a neurologist by background and at community health systems for about 13 years in areas of clinical operations, but now totally focused on innovation. Not really defined what that means, but working through that. Community health systems were 70 some odd hospitals across 15 states. So very distributed. We have 43 distinct markets. So trying to innovate on that kind of platform creates some complexity. So, I think that when I think about sort of the foundations, I really think about organizational culture. I think about organizational alignment, collaboration, communication, how do we get things done? So I know you'll force me into talking about technology at some point, but I think I really have to start with what are the foundations about how we're able to enact change within the healthcare system. And healthcare systems are sort of not your beacon of change and innovation. And so that's what I think, my job is to figure that out, and working very practically to figure out how do we move quicker? How do we do things more, faster? How do we test things? How do we pilot them, but not just pilot them, but pilot them quickly and then scale them? So when I think about foundations, I think about, again, collaboration, communication, culture, and ability to move more quickly in adopting the technologies we know we need to adopt.
Okay, great, thank you. And do you feel like technology is still an important aspect of the innovative roadmap that you're building?
Yeah, there's obviously a lot of talk with Gen AI, et cetera, and I think we're at this inflection point where, we got through the pandemic, which was, a crisis, and we did all the things with telemedicine, et cetera, that we were able to do. I think now there's still pressures, workforce pressures are one of the biggest ones that we see. We're going to have to use the technologies that are available to help us, succeed economically, to provide the patient experience that we want to provide. So, we're working maybe one of the first places on our physician call center to automate so we can create almost a 24/7 experience to serve the patient when they have a need. They don't have to wait till Monday through Friday where there's an agent to answer the phone. How do we automate and use Gen AI to serve the patients, get their needs met more quickly, provide better service, better communication? So I think we can use that technology, but we have to be, good at trying to figure out what are the right ones, how to use them, and how to be safe in using them.
Yeah, no, yesterday I was talking to the team, and there were enough panels that talked about use of Gen AI, but the ethical use of Gen AI and not knowing where to use them and where not to use them, especially with some of the executive order that we just saw President Biden sign. Mike, you come from a very different angle as someone with deep roots in the plant side of the business. What do you see from your vantage point?
Sure, thank you. So Mike Vennera, so I work for Independence Blue Cross, Blue Plan in the Philadelphia region, but also operate outside of that area under an Emids Health brand in a number of states serving Medicaid and some commercial lines of insurance. So I run both strategic direction for the company and then also a lot of our strategy execution with IT and operations. I think when I think about innovation across the landscape, to me there's a couple of different elements that are important. So technology is a huge part of it. I mean, I'm responsible for technology at our plan, but that's only one element, and technology in and of itself can't get the job done, right? Because you also need, on top of that, or working alongside of it, there's important issues of business model, right, that go along with the technology, and then there's important issues of trust, right? Whether that's a patient trusting information coming from a health plan, or a provider and payer trusting the information they share with one another. And just one anecdote from at least a number of years ago, so this is a little bit dated, but we entered value-based arrangements with a lot of our providers in the Philadelphia market 7 or 8 years ago. We started exchanging data, right? So we started saying, well, look, you're taking risk on a set of members. You need to know everything about those members, including care that was delivered outside of your health system, and including the cost of that care, right? So we started sharing that information, and you think about the intent behind that, right? Around how do you get providers to, start steering members to lower cost, settings, how to manage care. And the discussion I immediately got in with the CFO at this provider system was like, well, why are you reimbursing that other system more than us in this, area, right? So you kind of think about there was a place where we had the technology, but we didn't have the right business model or trust level. Now that has evolved, at least in our market over the years. So I think today we're in a much better place, but that's a good example of how you have to have, those things alongside the technology to really make innovation work.
Great, thank you. Thank you, Mike. I want to connect back to what you both talked about for just a minute, and then we'll move. You talked about trust. You talked about org culture and some of those. And David, you talked about time spent of clinicians. I'll come back to you on, Oracle's doing a phenomenal job of, as you talked about, financial systems to EHR. Does the clinician, does the doctor, does the patient all feel the level of trust in data and integrity? What are your thoughts on some of those? Do you still feel like, in the end, is a patient really worried? I'm picking a patient in this thing about his or her or their data going across, or do they rather have data shared to get better solutions?
So I think it's even more fundamental than that. I think when a patient shows up and we ask them 8,000 times to give their family history,
Yep.
and we hand them a clipboard that they fill out and nobody reads, when the MR machine isn't working and they can't get their MRI done, forget about, we shouldn't forget about it, but put aside, cybersecurity and data privacy.
Yeah.
Those are just ways to eliminate trust. Like we basically say we haven't been expecting you, where when you go to anywhere else in retail, online, or brick and mortar, we say we've been expecting you. Oh, welcome back. Oh, it looks like this is what you want to buy next. We don't do that in healthcare. And I mean, look, as a practicing physician, there are times where you don't know what that consultant said, and patients don't get it. But when I say to them, hey, so what did that consultant say to you? It's because I'm trying to get the information from the patient that I should have got from the consultant. So we have so much to do with trust. Then we can get to the issue around, can we keep the data private? Everybody, I'm exaggerating, wants to keep their information private, and almost everybody has no problem if in a de-identified way you use it to make healthcare better for me, my family, my neighbors, and the world. And but hey, before we do that, we got to get rid of the clipboards, right? I mean, we gotta really establish that we're modern and professional, and we've been expecting you. Then we can get to the question of, would you like to participate in this trial? Now, obviously, we're doing both at the same time, but to me, it's more about, if you actually love your patients, you would never not know whether they got their colonoscopy or not, right? And so, to me, that's where it fundamentally starts. And then, in my experience, if you say to people, hey, your information can help other people and we can keep it private who you are, almost everybody goes, I'm in.
Thank you. I want to switch back to you, Lynn, to move from the opportunities to some of the challenges that you're facing. And there are many, as we started talking about. But if we think about two key areas to say, we're talking about our foundations. What are the infrastructure and data challenges that you're faced? I mean, you're doing this massive transformation and innovation at CHS. From that perspective, it'd be useful to just hear a bit about what are some of those that you face.
Yeah, it's hard to focus on just a couple, but there are many. As a clinician, I think I've always sort of started kind of more at the sharp end and kind of, at the care delivery end. But I find in what we're doing now, I got to move so far upstream and work, again, that collaboration, but internal collaboration, between the clinicians, operations, and IT infrastructure. So I think we've talked more about the architecture of what we're doing, more than I ever have in my entire life. And we've talked more about platforms. And I think that issue of platforms is really a challenging one for health systems, because every new, idea or thought or solution comes with a different platform, and we can't manage 1,000 different platforms. So I think coming up with a platform strategy by which you can develop and deploy some of these solutions is really important. And I know we're being much more intentional and thoughtful about that.
And what about organizational clarity and some of those kinds of things? Do you feel like that is an important aspect of?
Yeah, so I mean, really, we can spend a lot of time talking about what we might want to do, but at some point you have to decide, make a decision, and move on and execute. And I think that organizational clarity about, what are we going to do, what is the direction, the timeline, and who's assigned to complete those tasks gets really, has to get really very granular. So I think we like to, the ball's always moving as far as innovation, but at some point you got to plant your stick in the ground and say, this is where we are and that's where we're going, and then provide the resources to get there, the people, and the technology to get there.
And the biggest challenges you face today in getting that piece, maybe was, or blockers.
Yeah, I don't know if it's a challenge. I think, getting that alignment about where we're going when there's a moving target all the time. And I think sometimes just that intentionality of decision making, and then, making that decision and then trying to figure out, is that flexible enough that you can change as the environment changes? So I think sometimes we get in the mode that we, want to keep discussing and come up, and perfect is the enemy of good. Sometimes we got to figure out what our strategy is. So again, defining the strategy, having the leadership do that, communicate, collaborate, and, I think have the stakeholders at the table to understand, what we're trying to achieve and where we're going.
Mike, your views on it, it'd be useful to understand what are some of those blockers for innovation.
Sure. I would absolutely agree with your point around sort of the point solution. I often hear the term point solution fatigue. There's just so many niche vendors of solutions for what are really niche problems in healthcare, right? Your program or solution to help a diabetic doesn't help depression, doesn't help someone with CHF, right? They're all sort of unique. But for any entity, right, a plan or a provider to sort of manage like this broad number that are on all different infrastructures and different portals is a real challenge. So I think as an industry, right, there's an opportunity out there to figure out how can we come up with a platform, if you will, that would tie all that together and make it a little bit more seamless. So I think that's a big challenge for all of us. When I think about just then kind of within a plan, one of the challenges when we think about data and having data innovation, there's a big foundational investment, and this panel's titled Foundations. It's important to invest in a foundation, but foundations they're one step removed from business value. Everyone wants to pursue, a business use case, right? That we're going to do this for our members, we're going to do this, to enable our providers. But you have to almost step back and build a solid foundation, and that solid foundation, one, often costs a lot of money. Two, takes a lot of time, and in and of itself doesn't provide value. It's what you then go do with that foundation. Yeah. Mm-hmm. But it's sort of getting the buy-in to make that big, that investment of time and money to create that solid foundation is really critical if you want to be able to innovate in the future. I would say just a third area to kind of come back to the point I was mentioning at the beginning around trust, and point David you brought up, payers at least sort of face out to, our members as a large institution. And large institutions don't have a lot of trust, right? We're paperwork, we're online forms, but we have a lot of great resources, right? We have a lot of great information, a lot of great analytics we can bring to bear. Within the payer industry, we like to think our business model is very aligned with people, right? We do well when you don't get sick and you stay out of the hospital. We think that's what people want. That's kind of what we want as well. But we have a low trust score, right? People do not want to get an email or a text from their payer. We do it, but that's not what they trust. They want to hear from their clinician, right? The doctor, that they have a personal relationship with. So how do you get the resources and tools and data that we have available as a plan and get that effectively in the hands of a frontline clinician to drive behavior change? And it's easy to say, but it's hard to do.
Can I jump in on that?
Yeah, of course.
Yeah. So that's exactly what we're trying to do. And I think you laid it out perfectly. So we want to create that open and connected platform. We're humble. We don't want to do this by ourselves. But this open and connected platform that allows that data to flow so the nudge can be done at the clinician level, but they have the right information. So that the plan and the provider can say to the patient, not only did you have a great experience, but when you walk out, you know exactly what you owe, right? So that it becomes transparent to whoever is in the system by connecting it. And then to your point on use cases, okay, so let's say we connect all this stuff, ERP, supply chain, cloud, human capital management, clinical trials, claims processing, and the electronic health record, right? Those are our assets that we want to connect. Well, what does that mean? So a nurse is giving chemo for the very first time in your hospital. you guys have no idea, right? But we do know it in human capital management. And if we can bring just-in-time training into the EHR, you have a huge improvement in quality. The surgeon in your facility is dictating a note or ambient listening to do my op note. That's great. It should also drive supply chain, right? So we think we can connect all these things, and then to your point, it should be super less expensive, because if these integrations are done by the people who know how to do the tech integrations, as opposed to saying, hey folks, you have to pull all these things together, we can actually, we think, take a lot of cost out, make the system intelligent, and then there's a bunch of these use cases on top. So that's exactly what we're attempting to do, and we want to do it with others. We want to do it together.
But it's a great point. What are the challenges in that? Is there an adoptability challenge? Is there a cost challenge? You talked about cost, so it'll be to hear.
I'll do my introduction now. So I was the CEO of Cerner, and we got bought by Oracle. I'm now the chair of Oracle Health, and previously had ran health systems and worked at Google. And I presented to the Oracle board, and when they were thinking of buying us, and I thought I did a good job. But Larry Ellison didn't say anything at the end. So I asked my colleague at Oracle, hey, Larry didn't say anything. Was I okay? And he goes, oh, he was effusive. You were fantastic. But there's one question you answered that he really didn't like. And I'm like, oh, what was that? Well, some board member, I think it was Leon Panetta, asked me, so how long is all this going to take, this concept? And I'm like, I don't know, it's healthcare, 1 or 2 decades. So he didn't like that answer. So what's the challenge is we do these stupid pilots and we don't scale it. We have technology that exists in the rest of our life that we haven't brought. We talk about innovation of telemedicine. Guys, it's FaceTime. It's FaceTime with your doctor. So our problem is we move way, way too slow. And I think people say, oh, it's regulatory. I think it's your point. I think it's cultural. Yeah. I think everyone in healthcare is trying to do their best, but we are totally failing. If you look at the cost of healthcare, our outcomes, particularly in the United States. So I think my new boss is actually right. This shouldn't take 1 or 2 decades. This is crazy how slow we move. So I think the problem is all of us.
So can I just jump on that for 1 minute? I mean, I think I would, I agree culture does play a big part in it. And the example I always kind of like to use with people is I think about the Apple Watch and the EKG on the Apple Watch. And I think no one in healthcare, no established player, no payer, no provider would ever have endorsed that in its early going because it was kind of faulty, right? But Apple wasn't afraid to put that out there, knowing that they would improve it over time. So that gets to the cultural question, but I still think there's also business model questions. Where I hear a lot of people talk about the patient experience or the member experience, and why isn't it as good as in retail? And I think about the Amazon app, right, which I love, because every time I'm on it, it's a chance for Amazon to make money. So there's a huge incentive for them to pour a lot of resources into making that great. The business model is not just lined up that way in healthcare to really invest, right? It's just sort of so much more complicated, right? That if a provider system invests in a great patient experience, it doesn't necessarily translate to their bottom line like it should theoretically over time in a complicated way, but it's not direct.
But you said it. You said in Philadelphia, we did value-based care with our trusted providers. And the question the CFO asked you is, how come I'm not getting a better fee-for-service rate? Yeah. That's us, guys.
Right? No, I know. Yeah.
And I'll jump in too. So we're an Oracle partner, we're a Cerner partner. So I look forward to working with you and trying to, execute on that vision. But I think it does come down somewhat to economics. I mean, hospitals are struggling, and so what is the immediate value that can be extracted from the system? Because I know that when I have to present, we're going to do this innovative thing, it's got to be very crisp on what the very hard, tangible ROI is, and I got to start with that, and then maybe later we kind of get some of the other stuff. But we got to get very crisp about the economics to drive this.
Yeah, I think as we think about, there are, you draw parallels to financial services, retail, healthcare. I find it far more complex, right?
More complicated.
The consumer is not the actual buyer at all times. There are multiple people paying for it. There are multiple people taking the same dollar, if I may use that word, right? There's $1, there are three parts of the equation, and everybody wants more of that same dollar. And you go to Amazon, you go to Best Buy, you go to any of these things, and as you said, you walk in, they know who you are, they know what you're looking to buy, and or what you've thought about it. Whereas I think in our industry, it's like the data and the information by itself is segregated through multiple providers. And I think everybody makes a point, not sure if it's regulatory, let's put regulations out of the equation, but I think it's just somebody needs to connect the dots. Somebody just needs to connect the dots. And I think that's the biggest challenge. I want to switch to a bit about, we talked about opportunities, we talked about challenges, but I'll, switch to a little bit of solutions and what we are seeing in ideation to be able to solve some of this. So we'll start with you, Mike. As you're thinking about problem solving, how do you ensure that the problems that you're solving are benefiting your members versus a performance criteria that the CFO said, hey, how come I didn't make more money? I mean,
right.
that's an example you brought about, saying, in the end, how do you validate that?
Right. Like I said, I think, at least the payer industry likes to tell ourselves that our financial interests are aligned with our members' health. But, that aside, I think there are times when you have to make bets on things that you think are right, even if they don't have a near-term financial return, or even if they have a near-term negative financial return. I mean, one of the big things for us, and I think for a lot of the industry in the last couple of years, is trying to really make a big push with behavioral health and have that integrated with physical health. So we've partnered with the company Quartet to really drive connections as people are in their primary care offices if they have a behavioral health need with a behavioral health provider. We also upped our reimbursement for behavioral health in our market, knowing that just historically it was kind of underpriced. So both of those things in the short term are not necessarily going to help us financially, right? Paying more for a service and getting more people to consume those services. Now, could it have a long-term return? Possibly, but I think it's more about it's the right thing, right, for the members, and we believe it will have a benefit holistically, but that's a much longer thing to look at. So what we're focused right now is just those metrics around, can we get more people, that need a behavioral health care to a behavioral health provider? That's sort of one example of where we're looking at data. Just another example I would just bring up, because I think it's one of the most powerful things that I've seen that we've kind of produced from our plan, a analysis that my team had done. If I can describe it, the y-axis was the percent of admissions that followed a non-avoidable ER visit, and the x-axis is the social determinants of health. And a clear correlation, right? If you've got more social determinants of health, you're much less likely to be admitted to the hospital. And then you separate that chart and you do white versus non-white members. And again, you see a huge difference between the number of admissions. Again, even within the same socioeconomic status, whites admitted at a far higher rate than non-whites. So this is information, again, we can produce, but it's really, we have to take that out. We've taken it out and shared that with our providers, and a lot of them are like, but we weren't even aware this was going on. Yeah. Right? And so there's no good answer to that. Like, we don't have an answer right away, but it's the start of a conversation. But that was another example where it wasn't really about financial performance, right? Because again, an admission costs us money, but it was about, are our members getting the right care? And if there's, a discrepancy based on economic status or race, that's definitely doesn't make sense.
Doesn't make sense.
So that would be another example of kind of where we're focused on. They're not just necessarily the bottom line.
I think it goes back to a bit of the trust conversation that you talked about earlier, saying, how do you get your members to trust you? Because I look at my plan and saying, are they just trying to stop me from going to the doctor, or are they truly interested in my health that keeps me away from going to a doctor for the wrong reasons or whatever it is, right? So I think there's going to be that challenge, right? Saying they don't want me to go to the doctor. How do I trust my plan that they really want me to go to the doctor for the right reasons and the right times and be more healthy? And I think that's a point that you said is how do you get that trust built in? I'll switch to Lynn. And
what went through my mind is when we talked about trust trust with our clinicians that we're actually going to provide them tools so they can take better care of their patients. So, you talked about, pilots. I think from my standpoint, I don't want to spend all my life on something that's going to stay a pilot and never scale. And I don't want to spend all my time spending, working and not having some, the value be very tangible at the end, and not just financial value, value to the patient, value to the doctor. So specifically, we're doing remote patient monitoring, which is not a big, technological change, like you said, but getting in the hands of the docs. And a couple weeks ago, we had 6,000 patients enrolled. A few weeks later, we have 8,000 patients enrolled. It's growing like crazy because the docs trust, it works. It helps their workflow. The patients love it because they have it, they're getting better. They have somebody that's monitoring their care on a daily basis, not every few weeks when they come to the doctor. So it really is working for everyone, including the workload and the workflow. So I think if you can get things in the hands of the clinicians that actually work and add value to their day, to their patients, then the next thing gets easier. Now we're doing behavioral health, like you talked about, and people are going, oh, that last thing worked pretty well. Let me try this one. And we can get that trust and we get, things moving a little more quickly. So I think there's a lot of trust issues, not just with the patients, but providing value to the clinicians as well.
And on that note, Lynn, a point or two about what you work on patient experiences, care delivery, all of the above that you just talked about, and trust. How do you ensure a couple of things, a few points around how does it beyond putting the trust in the clinician or the doctor? What else can, at CHS, a sense or two of what you're working on to see how does it finally impact the patient a bit?
Yeah, again, it's a team. Healthcare is a team sport. So everywhere from, the technology to clinicians, the stakeholders are, the finance team, the people that are doing the model to see what is the value. We all come together and try to say, what's the goal? What's the endpoint? What are we trying to achieve? And align to that, and then monitor whether we're achieving that with, whatever we're implementing. And then, to your point about point solutions, not just saying, yeah, that was great, where else? How do we kind of continue to stack solutions so we actually, along the way, actually transform the way we deliver care? So it's not just a one and done, we delivered that, but how do you put things together so the interaction between the patient and the doctor actually changes over time and morphs into something that is more personalized and, more value at the end of the day.
Well, thank you. David, I'll let you have the last say here. As you said, technology is an enabler, and at the end of the day, it comes to how we use technology to help people. Some thoughts around you, how do you drive the data? We've talked about three different, I'll talk about myself as the patient, 4 different perspectives. We could say, hey, leave the data in the hands of the plan, leave the data in the hands of the provider, leave the data of somebody who can connect all of this, or leave as a patient and say, I'd like all of it myself so that I know where I can do and I can do what I want with my data. So it'd be useful to get from your perspective, how Oracle and you have been driving some of these things to get data-driven insights across, and what are some of the things that you're thinking through for the ecosystem and the chain?
Yeah, let me give an example. It's actually pre-Oracle that I think answers what you're asking. So when I was at Google with NHS, we were actually on top of a Cerner platform. Because I think it gets this anecdote, hopefully gets all the pieces here. we wanted to see, could we improve the rapid response team's ability to treat acute kidney injury. So in hospitals, often there's a nurse doctor team that gets notified if somebody's getting sick that's already in the hospital. Go see these people and try to prevent them from getting septic or whatever. And so in NHS, it was taking them 4 hours, the rapid response team, to diagnose acute kidney injury. We created an app, no AI, an app that just let them know when the creatinine, which is a measure of kidney function, went up, and the ability to diagnose acute kidney injury went from 4 hours to 14 minutes. There was a 17% reduction in the cost of care, and there were 30% less cardiac arrests. So just good UX, save lives, save money, patient was happy. I watched the nurse go in the room and say to the patient, hey, look, I'm Mary, and I just got notified your creatinine went up, and here's what we're gonna do. So you saw the trust, the tech, the whole thing was gorgeous, like beautiful. Then we thought, well, let's do AI. Let's do AI on it. So we took 70,000 patients and 600,000 variables per patient. So instead of creatinine, computer, we're gonna give you 600,000 variables. And the computer was now able to diagnose acute kidney injury, not in 4 hours like it had been done previously, not in 14 minutes like we had got it to with good UX, but in negative 48 hours. So before a patient has any signs or symptoms, with 90% accuracy, the computer said, this patient's gonna end up on dialysis. Like, if you're a clinician, this is mind-blowing. This is like, I don't know what I would even do. I guess I would, it's like anticipatory medicine. This person who looks really healthy is gonna be really sick in 2 days. Like, I don't know, I would check to make sure they're not on meds that are affecting their kidney. So that's the power that we now have in our hands. This ability to predict what's gonna happen at a level that's far better than human performance, like way better than human performance. That's the exciting part for the patient, for the payer, for the clinician, for the tech people. The scary part of it is we train that data on VA patients, which are 93% male.
Yeah.
The algorithm was only 50% accurate for females. So as we enter this phase of connect all the dots, use all the data, make these incredible models to be able to do these predictions, you know, was our data set biased to start with? Are we using the trained model on the right groups of people? Are we making the health inequities that we already know exist worse or better? So I don't know if I'll be invited back here in 30 years, but in 30 years, if this panel's up here, I sure hope they're not saying we blew it. Right. That we had what I think has been this perfect, we've been played the best cards. COVID gave everybody in the world a lesson on public health. Everyone knows mRNA, vaccine, bend the curve, like it's amazing. The new technology now is really powerful, wherever you lie on the spectrum of, is this new AI stuff, how cool is it? And healthcare costs, there's no way you can use the old playbook of, hey, let's cut some social work and get rid of some people in the cafeteria. Like, it's fundamentally broken, the cost thing. So we got all these pieces coming together, and we got this opportunity now to fix it. And I just think we need to do it really carefully. We got to go fast, but we have to be thoughtful that we don't want to create more problems than we already have. So that to me is how we're thinking about this big opportunity from a data standpoint.
Well, thank you. I hope none of us are here on this stage 30 years from now.
Or that we will.
There's just a picture of the 3 or 4 of us here on the stage saying, these guys solved all problems 30 years ago. That's how. But it's an interesting point. I think 2 points come up. I think running out of time. First, I think everyone talks a bit about bias, right? You train the model, it's 80% male. You talk about the white versus non-white bias. I think that's clear that there has to be a way to solve for bias. And I think technology is certainly helping at least understand that there is a bias when you look at data. There is a bias when you look at it. And the second thing, that's, I couldn't help but think through unplanned is partnerships. feels like there has to be a partnership of payers, providers, technology companies, and the patient
Yep.
to be able to solve these problems. So it's just it's something that we will not be able to solve without combining this partnership teams together. I know we could keep going on and on, but we're running out of time, and we have a great full agenda. Thank you all for spending the last 45, 50 minutes. Great time. Thank you.